Thank you so much for having me. It's a pleasure to be speaking with you today, and I'm really looking forward to sharing some of my work and what we're all learning together about Parkinson's disease and disparities and how we can address them through research. Okay, so the title of the short talk today is "The Only Way Out is Through," and we're focusing on race, ethnicity, and gender and Parkinson's disease. And that title is really born from an old saying that I used to hear my great grandmother say, and it's meant to convey the fact that sometimes challenges can't be worked around, that we really have to face our challenges head on, persist through them. So these are my disclosures. And these are our objectives. So I'll spend a little bit of time talking about what we know about race, ethnic, and sex differences in Parkinson's disease risk and outcomes. I'll then shift to describing a framework for understanding the mechanisms of observable disparities in Parkinson's. And then I'll wrap up by talking about some of our current efforts and provide some really practical recommendations for clinicians and researchers that might be used to reduce health disparities and to address the research processes that sustain health disparities. So let's just ask ourselves, what do we know about being diagnosed with Parkinson's disease, and does the likelihood of your diagnosis vary by race, ethnicity, or sex? So many years ago, our research group used Medicare claims data, which come from a large health insurance program that provides coverage for 97% of Americans over the age of 65, to show that there are some observable differences in the incidence of Parkinson's disease diagnoses. And so looking here, what we found is that in every race or ethnic category, there was a higher incidence in males as compared to females. So that's blue versus orange. And then we saw that across race or ethnic categories, we saw some subtle differences with whites having white males having the highest incidence, and Asian and Black males and females having a slightly lower incidence of Parkinson's disease diagnoses, adjusting for age. I will say that we repeated this analysis recently and found that even with later years of data, we see this pattern. We also see this pattern when we are examining the incidence of Parkinson's disease in other data sets available in North America. So, what does that mean? I'd like to focus a little bit on the sex differences. So, across the world, uh, across many different cohorts and populations, we consistently observe higher rates of Parkinson's disease being diagnosed in persons identified as male as compared to persons identified as female. And so the commonly accepted sex risk difference is 3 to 2. So for every 150 men that are diagnosed with Parkinson's disease, 100 women are diagnosed with Parkinson's disease. And we honestly don't know why yet, but we suspect that there are genetic factors, neuroendocrine factors, environmental exposures, either occupational or otherwise, and maybe molecular or hormonal factors that contribute to the fact that we consistently observe that males more frequently are diagnosed with Parkinson's than females. So those are sex differences in Parkinson's disease risk. However, keep in mind that particularly in countries like the United States, more women than men are likely to survive through and into older adulthood, and age, not biological sex, is the strongest risk factor for Parkinson's that we commonly capture. So in the United States, for example, at the age of 65, there are 125 women for every 100 men. And at the age of 85, there are 181 women for every 100 men. Of course, any clinician who is caring for a population that includes older adults commonly sees this in their clinical practice and patient panels. So, when you consider that there are so many more women than men surviving into the age at which they are able to develop and be diagnosed with Parkinson's disease, the actual number of women living with Parkinson's disease is very close to that of men. So, if you were to take everyone over the age of 65 in the United States who had a diagnosis of Parkinson's disease, nearly half of them would be women, and nearly half of them would be men, in spite of men having a higher risk. What that means is that we cannot use the excuse that male sex is a biological risk factor for Parkinson's disease as justification for research studies predominantly enrolling men with Parkinson's disease, because the actual population burden of the disease should have us recruiting nearly 50% men and 50% women. This is just what I said demonstrated. So again, we cannot use the male predominance in Parkinson's disease risk as an adequate justification for having research studies which overwhelmingly enroll men, because there are nearly as many women in the United States who have Parkinson's disease as men. So let's think about that a little bit more, and let's think about how we use demographic variables and how we categorize demographic variables and use them to inform statements and perceptions of risk, and use them to inform study design and research study design. On this slide, I'm let's see. In this slide, you can see that I've used some common demographic variables, and I'm going to explain how they may be used or understood in Parkinson's disease risk and disparities research. So on the left-hand side, you see race and ethnicity, and on the right-hand side, we see sex. So, race and ethnicity are social constructs that vary over time and vary across populations, and they reflect the social and cultural differences or perceptions thereof between different populations of people. Sex, on the other hand, is biological, it's chromosomal, and it results in measurable differences in things like cellular development and function and responses to external factors, including some factors that might be relevant for Parkinson's disease risk and Parkinson's disease course. So, minoritized race or ethnicity is a social risk factor, not a biological risk factor, for disparities in Parkinson's disease care and research. And race and ethnic categories may align with varying prevalence or genetic factors or other biological risk factors that are relevant for Parkinson's disease. On the other hand, female sex is also a social risk factor for disparities in Parkinson's disease care and research, as I'll show in forthcoming slides, whereas male sex is a biological risk factor for Parkinson's disease itself. So it's important to understand that social risk factors vary over time and may or may not align with biological risk factors. And biological risk factors or categories of biological risk factors may sometimes also serve as social risk factors. Let's talk about what I mean in a couple more slides here. So when we're talking about disparities, we are, uh, I want to show here that this figure does a nice job of explaining what a disparity is. So in its simplest form, a disparity is a difference between two groups. And that difference can arise from factors that are clinically reasonable. They can be uh, appropriate or inappropriate, and not all disparities require or would ever respond to current interventions. So you can see here group 1 versus group 2, assuming that the two populations have equal access to care. The difference in the health care or health outcome could be due to appropriate differences in need, disease severity differences, differences in disease risk. It could be due to difficulty accessing a healthcare provider. Uh, it could be due to trouble with physician availability. There could be differences in the ease of completing treatment. Social determinants of health and the quality of the medical care that's delivered can also contribute to differences and would be viewed as disparities. Sometimes our observed disparities are due to a lack of adequate research data. There can be treatment uncertainty or underrepresentation or limited subpopulation data. And then finally, differences or disparities can be due to bias, prejudice, and stereotyping. So let's go back to our initial question, which is, are there race or sex differences in Parkinson's disease risk and outcomes? We talked a little bit about Parkinson's disease risk. Let's talk about Parkinson's disease care outcomes. In this study done by my colleague Nabila Dahadwala at the University of Pennsylvania, the odds of basic care for Parkinson disease, that is, guideline adherent care for Parkinson disease, was studied in a single insurance population of persons who are receiving Medicaid in the United States. And the outcomes were, did the person receive medication or physical therapy, or did the person receive just medication therapy? And what Dr. Dahadwala found was that persons diagnosed with Parkinson's disease who were identified also as African American or Black had a much lower odds as compared to whites of receiving medication or physical therapy, the basic care that we are to offer individuals with Parkinson's disease. And persons who were African American or lived in urban areas also had a much lower odds of receiving medication therapy for Parkinson's disease. Older adults, for both outcomes, or older age, being in an older age group, was associated with a higher odds of receiving guideline adherent care for Parkinson's disease. And we don't know the reasons for these differences. And if you certainly think about the last slide I showed, there could be any number of those reasons could apply to the pattern of outcomes that we're seeing here. So that's basic care. Let's think about advanced care. So this study, done by our group using Medicare claims, which again focuses on older adults in the United States, showed that uh, having a race or ethnic group identifiable as Black or Asian was associated with a substantially lower odds of receiving deep brain stimulation surgery for Parkinson disease and uh, being describable as female was associated with a substantially lower odds of receiving deep brain stimulation surgery for Parkinson disease. And I think that the sex differences is critically important in light of other observational data which suggest that women are more likely to have dose limiting side effects from Parkinson disease medications, are more likely to have dyskinesias, and have greater gains in quality of life after DBS surgery occurs. So, finding that women may qualify for, but seem to receive deep brain stimulation surgery less often is concerning. Let's keep thinking about Parkinson's disease outcomes with this slide. So, one of the things that I really enjoy examining is pharmacoepidemiology, drug-drug, and drug-disease interactions in Parkinson's disease. And my cross-training in pharmacoepidemiology allows me to take unique perspectives sometimes. So this study was actually inspired by a patient encounter, as I'm a practicing Parkinsonologist, like many of you, and I was referred a patient with end stage Parkinson's disease. And we know from the literature in the dementia uh, research community and in the geriatric research community that there are medications known to impact thinking and cognition in older adults, and that knowledge has driven recommendations from the Geriatric Society and other leading aging and geriatrics societies against the use of such medications in older adult populations. And so in this case, with my patient, I discovered or recognized that she was taking several medications which could negatively impact thinking and ability to walk, and slowly weaning those medications and replacing them with therapeutic alternatives that did not have those potential side effects resulted in measurable gains in her cognitive ability and mobility and safety. So I started to wonder after that patient encounter how pervasive drug-drug and drug disease interactions might be in the Parkinson's disease population. So in this case, we performed a pharmacoepidemiology study of over 268,000 older adults with Parkinson's disease, and we found that 42% were being prescribed a medication that might cloud thinking in an older adult, especially one with Parkinson's disease. And even more concerning, in my opinion, we found that 45% were taking two medications that could oppose each other, one that could improve thinking and one that could impair thinking at the same time. So we also found that women and minorities were more likely to receive those inappropriate medication combinations. And if you think about that, given that drug safety is not a strong focus of training or clinical practice yet in Parkinson's disease, how might those medication combinations affect our clinical trajectory measurements and observational research? Or how might those combinations affect study eligibility? Looking at the map here, we found statistically significant clustering of the prevalence of what I call a prescribing error, with high clusters of using these two medications with directly opposing mechanisms of action, occurring also in parts of the of the US where there's lower neurologist availability, or there may be additional challenges in receiving specialty care. It's important to note that current research guidelines do not consider the burden of medications that could negatively impact cognition, and observational studies which have cognitive trajectory or outcome, um, or which have cognitive trajectory as an outcome. And so we could be facing some issues with our measurements due to medication combinations. All right, so given that we observed some sex-based differences in care and outcomes, we decided to look more deeply. And in a series of studies, we found that women who were diagnosed with Parkinson's disease and persons who were from minoritized race or ethnic groups diagnosed with Parkinson's disease were less likely to visit a physician, more likely to be placed in a skilled nursing facility or be hospitalized. They were less likely to receive basic treatments for Parkinson's disease or surgical therapies, as we mentioned. They were more likely to receive the potential inappropriate medication combinations, and they were less likely to participate in research or ever be asked to participate in research. So, what forces might underlie these patterns, and how might these patterns influence our perceptions of disease risk or disease course? So, let's think about that first question a little bit. What factors might limit our current understanding of the disease course of Parkinson's disease in women and in minoritized group? And a couple of things come to mind. Number one, social determinants of health. Number two, discrimination and racism. And number three, sampling selection and confirmation bias. I'm going to walk through each of these a little bit. And I want you to think about how you collect data in your clinical research studies at your own centers. So, the social determinants of health are the environments in which people are born, grow, live, work, and age. And these circumstances are shaped by the distribution of money and power and resources at the local, national, and global level. Social determinants of health have been shown over and over outside of neurology research communities to be mostly responsible for the health inequities that we observe. They're often multi-layered, and they range from individual factors, which you can see at the center of this slide, to societal factors, which you see on the periphery. This model is one of the most commonly used frameworks to help us understand the social determinants of health, and it shows the relationship between individual, community, and larger scale social determinants of health. And it shows the relationship between an individual and their environment. Um, However, there are some elements which are missing from this model, which I'd like to touch on. Discrimination and segregation are two elements that are missing from the commonly used social determinants of health models. And they are also missing from most discussions about health disparities inside and outside of neurological conditions. To understand the potential impact, I'd like to point your attention to some data that was evident during the global COVID-19 pandemic. And in this study from the CDC, Americans were asked about their experiences with the medical profession. And this was part of a series of studies which was trying to understand patterns of healthcare seeking behavior. And what was found is that over 40% of persons who self-identified as Native American, African American, or Latino reported that they recently had a medical encounter with a physician or a member of the medical profession during which they felt discriminated against. And I think that uh, that is a point that cannot be overemphasized, that perceived, real, persistent discrimination and differential treatment uh, of persons who are from minoritized race and ethnic groups is pervasive and quite consistent these still. The other thing to consider is segregation. And again, this is a driver of health disparities. That is a social determinant of health that is under-recognized and doesn't receive sufficient focus in current research study designs and research data interpretation. Understand that due to racist and anti-immigrant practices in the past, not everyone in the United States has the same opportunity to be healthy. And I think this picture displays that wonderfully. You can see here that where you are born can result in you having a lack of access to healthy food, lack of access to green trees, cleaner air, noise pollution, and whether you were born here versus born here was largely not dependent on your talents or your merit, but rather your appearance or the social risk factors that you have for discrimination and segregation. So the third potential driver, in addition to social determinants of health, discrimination and segregation, is underutilized and under-recognized social determinants of health. The third factor that could be driving some of our observations are sampling and confirmation bias. And so in this slide, um, uh, it this concept is demonstrated in a way that is easily understandable as a disease specialist, perhaps working in a specialty center. So here are the dots of the entire population. And in this circle are the dots that consist of the data that you use, the population that you are sampling from. So if we are thinking about Parkinson's disease, out here are all of the women that aren't coming to or can't access or don't feel comfortable at academic research centers. In this outside part are all of the older adults who have mobility issues. Out here are all of the undereducated adults who don't think that or aren't aware of Parkinson disease specialty care. And people who live too far away to drive don't have social support, don't have social capital to get into some of our clinics with really long wait lists. These are all the people who can't make a phone call and get bumped to the front of the line, people who live in rural areas. And then these are the people we sample. And so it is not surprising that our samples consist of graduate school educated males who are from higher socioeconomic strata many of whom also have some social capital that supported them and have excellent social support systems. Now, it's wonderful that we are giving care to that group, and we should. But as we are thinking about how we view Parkinson's disease course and trajectory, and how we design and develop strategies for whole health or whole body treatment of Parkinson's disease, we have to consider that all of the people who aren't making it to our center are also those who likely have competing comorbidities, which may complicate their exam and make the diagnosis less clear. They may have competing needs for other treatment. And so I'll show next in some examples of how that can manifest and how we can unintentionally draw inappropriate or incorrect conclusions from that sampling bias. One of the most important things to remember as we're thinking about this kind of work is that we as physicians are generally really kind and altruistic people. And so most of what we have seen evolved has not been based with malintentions or negative intentions. And yet here we are. And so thinking about the title, The Only Way Out is Through, one of the things that we have to do with and for each other is understand that through no clear malintention or negative intention, we have processes which make it difficult for some people to receive care as compared to others. And with that neutral, open, and altruistic mind, we have to start thinking about ways to address that. So, with that in mind, let's go through some Let's go through a couple of scenarios. These scenarios represent kind of amalgamations of real people that I have seen during my time as a practicing Parkinson's specialist. So here you can see that um, I've created a couple of different prototypes here. And so let's start here on the column on the left. So you have a 73-year-old former female teacher's aide. And if you've heard me give talks before, I always say this, a retired rural teacher on a pension. Um, does not often get represented in our clinical trials, our observational research, or captured in our understanding and documentation of what having Parkinson's disease is and isn't. So here is this 73-year-old former female teacher's aide who has a tremor. She comes from an area where there are few specialists. She has a high copay for referrals. She sees a primary care physician who has a lot of patients, and as part of their practice style, doesn't usually refer out to specialists. That primary care physician also has a patient panel in which patients themselves don't demand referrals. Socioculturally, she's someone who grew up not wanting to be a burden. And as she's become an older adult, she also doesn't want to be a burden. Her children moved out of the rural area that they grew up in, and they're not very involved. She's fine with them living their lives. She doesn't want to press them. Behaviorally, she likes her physician to make the decisions. She doesn't press or push back. To she doesn't arrive with Google searches and research for her appointments. She really trusts in her longstanding MD and wants him or her to guide her medical care. She prefers few medications. She's not physically active. She has a typical American diet. Biologically, she has severe hypertension. It's undertreated. So her clinical course is that she's accidentally misdiagnosed as having essential tremor for the first 5 years in her Parkinson's disease. Because of all of these reasons that I've just mentioned, she has a higher threshold for symptom burden. She has a lower likelihood of being referred to a specialist who could differentiate essential tremor from tremor dominant Parkinsonism. She's finally referred to neurology out of concern for vascular Parkinsonism. She has an excellent carbidopa-levodopa response. However, because she prefers to take as little medication as possible, she's one of your patients who you always see as undertreated when you examine her. So then let's look at the next case, which is a 62-year-old male professor with a loss of dexterity and tremor. This person lives in an urban area that has a lot of specialists. He has a lot of academic institutions that he can choose from for fellowship based specialty care. He's in the 95th percentile for wealth, both due to his current uh, uh, job as well as due to inherited wealth from his family and a lack of debt inherited from his family. Socially and culturally, he has children and a spouse who are very involved. They live nearby. Behaviorally, he's physically active and he is up to date on preventative care. He even gets extra testing, cutting edge testing. And you could consider him, if you examined his healthcare patterns, as a super consumer of healthcare services. He gets rule out testing for many things based on his requests of his primary care physician and things that he reads in research manuscripts and in breaking news blogs or medical press releases. His very first evaluation after he notices loss of dexterity and tremor is with a movement disorder specialist at his institution who diagnoses probable mild PD. He also has an excellent carbidopa-levodopa response, and because he saw a movement disorder specialist and he has a spouse and children who are very involved, and because he's highly educated and does a lot of reading and can tap into his highly educated social networks for advice, he begins exercising or continues exercising 5 days a week. He hires a trainer to keep him consistent and exercising safely. He changes his diet, even with the help of catered food or chef provided meals. And he engages with a support group. Let's look at our third. This is a 70-year-old male farmer with gait change. Not only does this farmer have few specialists in the area, there are few MDs or DOs in his area. He's self-employed, and so he has an insurance plan that has high medication cost sharing. Socially, he comes from a close, large family. There's several generations living together. They think of themselves and describe themselves as tough. They take care of each other. Behaviorally, he uses alcohol to excess according to current standards. Religion is an important means of coping. And biologically, he has severe diabetes and severe hypertension. His clinical course, he's only diagnosed with Parkinson's while he is hospitalized for a TIA, and the movement disorder specialist is the person doing consults that week. He has a modest carbidopa-levodopa response. However, he does pretty well with his ADLs. After his diagnosis, his children and grandchildren who are living with them or by, uh, help him with all of his ADLs and IADLs. So think about these three cases and how we might observe or consider their Parkinson's disease course. So for research participation, our 73-year-old former teacher's aide with a tremor might not be interested in research, although she's most likely to never be asked. Our 62-year-old male professor with loss of dexterity and tremor is very interested in research and contributes disproportionately to the research data sets at your institution. He participates in several studies. Our 70-year-old male rural farmer has inconsistent neurological care, may or may not follow up with you after the hospitalization for the TIA, and has complications of diabetes. He's got severe neuropathy, severe vascular disease. He had a TIA during the hospitalization. And that would make it difficult for him to qualify for research studies. So, what are we observing and recording about what we know about Parkinson's disease for each of these three individuals, based predominantly on things other than the biology of the disease? We might be observing or recording that the first case, the teacher's aide with tremor, has a high symptom burden and early onset mixed cognitive impairment. We might be recording, observing, or reporting that the 62-year-old professor has a low motor burden and a favorable slow disease course. We might be recording or observing that the 72-year-old farmer with gait change has severe dysautonomia, early cognitive impairment, severe cognitive impairment, and is homebound. But put all of these other elements together and see how what we are teaching, thinking, and understanding about Parkinson's disease can be highly dependent on factors other than the biological progression of the disease itself, and how what we might be recording about Parkinson's disease and observational studies, particularly those that don't include broader or more representative samples, might be giving us a small or incomplete picture of the disease itself. Of course, we can see that in this person and this person, their total picture, measurable with our standard disease scales, is influenced potentially by factors other than the Lewy body burden in their brains. And yet, without sufficient representation from groups like this, we have not developed ways of teasing out the relative contributions of comorbid disease from primary disease. And we haven't built that into our research and data collection processes. So now I'm going to shift to offering some really practical initial steps for how we can gain a greater perspective of Parkinson's disease as it's experienced by a larger proportion of the population. And I'm going to use a blueprint that was developed by the American Neurological Association in response to a need for a greater understanding of how social determinants of health can impact research data collection, research study design, and our interpretation of the results. So, what do we need to think about if we're going to address the health effects of racism and adverse social determinants of health? First of all, we need epidemiology studies, both primary and translational, that include understudied populations. And we have to collect genetic data, data on gene environment interactions, resilience, inflammation, and comorbid conditions. Think about how the comorbid disease, behavioral factors, and sociocultural factors for case 1 and case 3 affected the clinical manifestation and the clinical interpretation of their Parkinson's disease. It's important that this kind of work is co-led by scientists with expertise in these populations. Secondly, from a research perspective, we need mechanistic research on health disparities, also co-led by scientists with expertise in this area. We've got a sufficient amount of descriptive data at this point on rural, urban, and race and ethnic disparities and health outcomes for Parkinson's disease. We have to now start to think about the mechanisms. And in the case studies that I showed, I demonstrated some of the possible mechanisms by which um, social determinants of health can influence disease course, disease measurement, and perception of disease. Here's the National Institutes of Health Disparities Research Framework. And I recommend this as an initial framework for categorizing and understanding how social determinants may impact the measured health and health outcomes in a given population. What I like about this framework is that it separates vulnerable population status from the actual mechanisms. So here you can see are a list of priority or vulnerable populations for health disparities, followed by domains across which health disparities may develop and potential mechanistic pathways associated therewith. So if you think about the case studies that I presented, you will see that some of those factors that I added in fell under geographical mechanisms of health disparities. Living in an area with few MDs or DOs, living in an area where it is difficult to access a neurologist. There were also some healthcare factors. Having a primary care physician who has a very large patient panel, and as a matter of practice, in the absence of guidelines, having a practice pattern that doesn't favor referring out to specialist care. We can also see that there were some sociocultural factors about expectations for health, expectations for aging, beliefs about feeling well, and tolerance for not feeling well that could have impacted disease presentation and perception along every step of a Parkinson's disease course. So I like this framework. You can see there's several others here. I like this framework as a starting point for beginning to think about the mechanisms of disparities and seeing them as something beyond the lack of interest by members of a priority population in seeking or receiving specialty care or in having ideal outcomes. With that in mind, here are some additional practical recommendations. So if you are planning research studies or planning observational studies, one thing you can do in your clinical research practice is seek to create systems of unbiased selection for initial study recruitment. We have to move away from the practice of and teaching the practice of sitting around thinking, who would be the right study participant for this study? Who would be a good patient for the study participant for this study? Because whether we intend to or not, uh, what we consider as being an ideal study participant includes thoughts of uh, social support, of control over one's schedule, over enthusiasm, over educational achievement. And all of these things subconsciously together result in us thinking of highly educated, high socioeconomic status persons with control over their schedules as ideal participants. So it is not surprising that those are the types of participants that dominate our studies. We can and should and need to design studies that are accessible to more individuals and that ask study questions that are informed by and attractive to more individuals. The second thing we can do is we can investigate how our practices refer or refer new patients, uh, looking for inadvertent pathways that lead to our populations not reflecting the surrounding communities. Many of us at academic centers have noticed that our clinic populations don't reflect the community in which the medical school or center is built. And we need to examine in a very critical way what might be the inadvertent reasons for that. We should begin collecting data on social determinants of health in our clinical practice and in observational studies. Again, there has been a large body of data which has demonstrated that social determinants of health are stronger predictors of effective and quality health care than things like race or ethnicity alone. And then finally, we've got to start including patient stakeholders in our study development and in selecting and designing outcomes to be measured. This is one thing that our VA research community does very well. We have a veteran community advisory board, and having them review your proposed research and comment on it is a required non-negotiable part of a research application. I think this is something that should be come routine practice at academic and research centers, as it is sure to open our perspective to our patients' values and what they value in research, and it is likely to result in study design modifications that are more attractive to more participants. I'm going to end with talking about a couple of study design tips that can support improved, more inclusive research. We should start reconsidering demographic variables and recategorizing them as biological, social, and environmental. And we should avoid treating race as a biological variable. If we are going to consider progression, then we should separate and separately measure biomarker or biological based progression and functional progression separately. Think about those cases that I presented and think about how they would have vastly different functional trajectories, which again were independent of their Lewy body burden or of the amount of pathology due to Parkinson disease, and yet would be reflected in our standard research measurements for Parkinson disease severity to some extent. We need to revalidate our current scales in patient groups that consist of persons who are older, have competing comorbid conditions, and have average education. Only then will we know whether we are going to have troublesome outcome measurements due to being able to include more people with Parkinson's. Also, we should test our hypotheses in a way in which the majority group could have the less favorable outcome and publish the results. We tend to organize study questions, and we tend to publish studies which focus on study questions in which the majority group always has the more favorable outcome, and the minoritized group or women have a less favorable outcome. We need to reevaluate our motivations for doing this and move away from the practice of it as the only way to consider a hypothesis. For trials in which we are testing new care models, it is important to begin to evaluate the effects of that new care model on the current disparities as a primary trial outcome. A new care model or new intervention that does not also improve health equity or does not also, for example, reduce sex disparities in Parkinson's disease outcomes is not a new care model that's worth advancing. Reduction in disparities has to be a primary outcome in new care models and new intervention studies. So with that in mind, I want to remind us that the only way out of the disparities that we are facing in Parkinson's disease is through, and that's going to require rethinking and reshaping how we design studies, deliver care, teach and model Parkinson's disease care, but doing so should be made easy by the fact that the overwhelming majority of Parkinson's specialists and researchers approach this field uh, with values of equity and kindness.
Wow. Thank you so much, Allison. This was so edifying. My mind is blown as usual hearing your talks. And I
You're
think
so nice.
but I mean, I think you state so beautifully and really, sort of detail a systematic sort of pathway to where we are now, and why we think this way and how we've sort of come to where we are. And in some ways, I think the pandemic, and seeing just how it affected, vaccine campaigns and health outcomes and all these things in so many populations has really sort of, I think, opened our eyes to the importance of caring about this in a disease that we all love, and are passionate about, and how we need to do better. And I think we're a bit late to these discussions, but I do have hope with this sort of approach and the types of body of evidence that you're sort of collecting along with others around the world, that we can work together to make a difference. So I thank you for your time and amazing
Yeah.
sort of way of teaching us about this. And I look forward to hopefully learning from you more and working with you more in the future. Thank you.
Oh, thank you.